Very good point. Very good point. It's solved. Right, okay. So welcome to today's seminar. It's a great pleasure to host Dr. Timothy Tuti from the KEMRI Wellcome Trust Research Programme from Nairobi, Kenya today. We're at the Healthcare Improvement Studies Institute, for those of you here in the room or online who've not joined any of our seminars before. So we're part of the University of Cambridge. My name is Niels Peek. I'm here, I work as Professor of Healthcare, Data Science and Healthcare Improvement. And like I said, it's my great pleasure to introduce Dr. Timothy Tuti for our seminar today. So Timothy works on digital health interventions in neonatal and pediatric care in sub-Saharan Africa. And that's what his talk is going to focus on today. So we've got about 40 minutes for the talk. And then there's about 15 minutes for questions. If you're joining online, feel free to pop questions in the chat and I will read them out during the Q&A. All right, the floor is yours.
Thank you very much. Welcome all to my presentation. I'm going to be talking about building reliable clinical data pipelines for supporting decision-making in health facilities in Kenya. This is a project that has just been launched, funded by the Wellcome Trust, and it's part of my early career fellowship work. My name is Timothy Tuti. I'm a Post-doctoral Research Fellow with the KEMRI Wellcome Trust Research Programme in Nairobi, a program of around 800 to 1,000 people, roughly 200 scientists. And I work in the Department of Health Systems Research, and we focus on health services improvement work, which is what this is going to focus on. So by way of background, COVID-19 was able to expose a lot of challenges with the clinical and facility data pipelines in routine healthcare settings in sub-Saharan Africa and places like Kenya. Apart from vertical programs, and when I say vertical programs, I mean HIV, TB, malaria, you are typically specially funded programs in low resource settings. Outside that space, there's really very scarce quality data to support any decision-making and clinical surveillance. So because of the current inadequacies of the data that is being generated from the health system routinely, what has tended to happen is that policymakers, decision makers, frontline healthcare workers have had to rely on either periodic surveys that should happen once a year. They happen less frequently than that, or estimates from models such as the global burden of disease models, which are complex, unreliable, difficult to interpret, and with that also introduce such a lot of uncertainty in the decisions being undertaken routinely. So more focus on why the poor routine data from the health system. Most of Kenya's health system information collection process is paper-based. It's quite difficult to envision how electronic health records can be introduced in a way that makes sense to the economy of Kenya, because the current estimates are roughly around 2.5% of the GDP of the country will be required to even implement a reasonably functioning electronic health record for a country that is in debt distress. That's not going to happen in the short or medium term. So instead, what we have is health records information officers in the hospital who try to extract information from the paper records that you've just seen. It's quite a tedious work. And there are only like 2 to 3, for a high volume hospital, 2 to 3 for a department. So really, there's not enough people to do that work. And it's a manual process of trying to get that data out. And once they do that, once they actually collect some bit of data and report it onto the national data warehouse, there's never any feedback about the quality of data that has been reported, or it's very limited, unlimited to the vertical programs again. And also there's never feedback to the frontline healthcare providers about how that data ended up being used to make decisions. So really, for them, it's like, why are we doing this? What's the point? So that linkage between the actual data being collected and the feedback loops of the uses of that data and how it can be used to inform even what they're doing in terms of routine practice is quite weak or missing. I've mentioned the global burden of disease estimates, but also the other thing that the health system focuses on to try and generate information to guide insights on how they should structure the health system is the use of these periodic surveys. They tend to be very command and control structure type of surveys. So what happens is you're converting WHO guidelines on care that should be provided into quality statements that have summary measures or core indicators that then the Ministry of Health with some partners will go out to a subset of hospitals at least once every 2 years and try to do an assessment of some of those indicators. But what you end up with is data that tells you the capacity to provide care, not really much of what care is provided because of the way the surveys themselves are structured. So you have the service availability and readiness assessment, the service provision assessment, health facility assessments. So they're all focused more on the health facility and the services they provide, as opposed to what did patients actually get, what care they did get to receive, and how did that match up with what they showed up with the hospital and the current difficulties and challenges that the healthcare workers are experiencing. And secondly, because this has worked so well for sub-Saharan Africa, it seems like the go-to every time we want to do an assessment for how well the facilities are functioning, do a survey, which then is only happening in, when I say a subset, I mean like a fraction, like 20% of the hospitals, which not tend to be reflective of the entire country. They are more selected because of the ease of doing surveys there. So really, there's a huge gap on, okay, how much insights and information are we generating from the actual individual patient level data that we are collecting, that the healthcare providers might see. So the first challenge that this research project was actually looking to address was the issue about how we actually generate information that can be used for decision making from actual patient records, not surveys. So trying to move the question from can we assess a facility to can we actually say something meaningful about a problem that is affecting patients, and we have the mechanism to actually collect that data at patient level in a way that can be used to generate quality data that can then support things like functioning of a learning health system, which is the goal here. So most of the tasks between 1 to 5, which involve collection, assembling, and analyzing, interpreting data, are very weak because of the overworked health records information officers. And then because of the poor feedback flows, the issues around representing knowledge and how that actually ends up being consumed by the intended recipients is barely known, which is a huge challenge. So that first point of actually, let's first look at the ways we can improve the data is quite important. Secondly, the kind of challenge that I've put forward when it comes to the use of those surveys is primarily because they tend to be focused a lot on the needs, data needs, and information needs of international policymakers and national decision makers at the expense of the people who are at the lower part of that pyramid. So the health facility staff, the actual clinician who sees the patient, what information do they need to make decisions? So there's very limited thinking around their data needs. And because of that, what has ended up happening is that the focus has been on summary indicators that are important for the monitoring and evaluation structure of global health. That we like quoting, when you cite papers, but less focus has been given to things like continuity of care, because that requires some level of patient data that is quite of good quality. and things like quality of care that they actually receive. So those uses of data have tended to be disproportionately abandoned in our setting in favor of who are at the top of the pyramid. So there's a question there about how to actually make effective use of the data that we're already currently collecting in the paper records, not just those who are at the top of the pyramid, but also for the frontline healthcare providers. So in summary, the first goal of that research project, this research project I'm referring to, the Data Bridge project, will be to think about how we can innovate ways to improve on the efficiency of actually getting that data from the paper records into information that can be converted into meaningful insights. And that includes thinking of ways we can reduce the time it takes to extract that data, the effort it requires, and the human resource, because it's quite difficult to advocate for more health records information officers in a country in debt distress. It's quite difficult to make that case. But secondly, it's also to look at the ways in which care is provided within the routine hospital setting. So how patient flow happens, how the frontline healthcare workers handle the information as you're seeing the patients, and trying to design for that. So to design to target the data collection processes to match the current practices that are involved in taking care of the patient. But the second major objective for this project is also to think quite critically around the issue on how do we make a value proposition for the use of data in decision making, which has been weak because previously we have the way the reporting has been happening. There's been very limited feedback on what the data is being used for. So that confidence in actually this is the usefulness of the data you're collecting, and this is how it can inform things that are affecting the way of giving care and the patient outcomes needs to be made. And that involves looking at ways, number one, to integrate the data into routine decision making at the hospital level, but secondly, to kind of step back and like how we can make a value proposition for policymakers to start thinking more critically about engaging patient-level data for their own needs in terms of decision making. And within this is also strengthening the feedback loop. So we're collecting data, what is it being used for? That needs to be strengthened and made more available. I mean, the feedback needs to be made more available at scale to all the involved facilities who are actually reporting the data. So thinking about how you could actually do routine feedback, auditing feedback on the data quality and use at scale is a huge objective of the second part of this research fellowship. So how do we plan to do this? We are going to use the clinical information network. I have mentioned that what we're trying to think about is how such data can support a learning health system. What the clinical information network is a collection of around 25 hospitals, and we're working in their pediatric and neonatal care settings, inpatient settings, and they see roughly 1,000 admissions in each of those units a year. And we're working together with the pediatricians, the neonatologists who work in those settings, and the nurses who work in those settings. And we bring together academics and research institutions, but also the Ministry of Health. And what it's trying to do is, number one, think through how to better provide quality of care. I mean, how to better provide better quality of care, but also start thinking about interventions that can be used to improve the outcomes in this particular age cohort. For this particular fellowship, they focus on the neonatal part of the care that is being provided in these hospitals. So primarily because majority of the deaths in globally for pediatric children happen in the neonatal age, and some of them happen in Kenya. I mean, not in Kenya, but in sub-Saharan Africa. So roughly like 50% of those mortalities happen in sub-Saharan Africa. So there's a huge burden in terms of reducing the mortality that is occurring in this particular age cohort. But secondly, they're preventable, and it's the reasons for the mortalities are things that are preventable and things that can be easily I'm trying to avoid the use of easy in our setting because nothing is easy. It's more straightforward. I think is a better phrasing it in terms of how we will actually go around building a learning health system to actually support the improvement of care, but also reduce mortality. And then within this clinical information network, we have been able to collect roughly 500,000 patient encounters and 50 variables per patient encounter. So that's quite a lot of data that we have already. But we're going to zero in on 3 particular forms in our setting, which is the newborn transfer form, the admission record, and the discharge summary, primarily because they actually target care at very key milestones within the care provision flow. So the newborn transfer form will tell you what was happening as the baby was being rushed into the admission to be admitted into the newborn unit. And then neonatal admission record gives you information around the assessments that were done at the time of admission, the examinations, interventions that were provided, and the condition of the child at the time of admission. And then the newborn summary will give you information around what happened by the time they were being discharged, the condition of discharge, and their length of stay, and whether how those interventions worked. So the 3 of them combined will give you roughly 250 variables per patient. And the goal here is to convert them into machine-readable paper forms. I'll explain why in a short while. So why machine-readable? Remember, one of the key efforts that we're trying to do within this research project is reduce the effort time it takes to actually extract good data at patient level and make it available for decision making. So the design for using machine-readable paper forms is to allow the use of models, primarily artificial intelligence models that are more focused on optical recognition, optical mark recognition, so that you can be able to extract that data or automate at least most of the data extraction process from those forms in a way that makes it easy to convert this particular data in those paper records into actual formats that can be consumed by software such as business intelligence software, W, Apache Superset, those kind of things. So the goal here is to make it such that we convert paper records, which are not yet information, into actually things that somebody can actually look at, analyze quickly, and give insights. I mean, this is a starting point is that we think if we have machine-readable paper forms and a scanner and internet access, the moment you scan the record and apply the models, you have some level of patient-level data that can actually be reported directly into the national data warehouse and can be used for clinical surveillance. That is our starting point and the hypothesis. We are going to work together with the health records information officers to see which modalities of this implementation will actually make sense for them and can be scaled to the clinical information network to maybe a health facility in a health setting. But the overall goal of the first objective going into the future, not just for this project, is to think about how we will start extracting data from different varied sources of information. So not just records, but also from the smartphone devices that the community healthcare providers use when they go see the patient post-discharge, and try to link those data and curate them in such a way that they are easily consumable or by business intelligence softwares. So that's a very tech-oriented kind of objective somewhere in there, just making it easy for to get data from the healthcare system at the patient level. But going forward, what this will allow us to do is also start thinking about how you start integrating different sources of information, not just an electronic health record where there's none and paper forms are used, or where it's an outpatient visit and a smartphone device was used. So how do you start bringing that together, linked to one patient? Monitor, especially things like continuity of care, right? So that finishes the objective around data collection and making ease that process easy to the providers. But the second bit is now the information use challenge. This is where a lot of work actually, because up to now, the running hypothesis has been, if you collect good quality data at scale, belonging to different patients, people are happy to use it. That is not necessarily true. And that is not necessarily true because of different reasons. Now, I want to pause here and make a comment about a learning health system, because I have been mentioning it, but I haven't given you like a good way to fill out what exactly is a learning health system and not. But I think one way you can actually look at whether what you are running, whatever network you're running, is actually a learning health system is based on these three tenets. Whether you think there are actually tools, processes, and I will even include information that supports learning for the frontline healthcare providers, individually, as teams, or as facilities, whether you're allowing the people engaged, the stakeholders engaged in that learning health system to challenge the kind of assumptions on which the care they're providing are based on. And thirdly, how you're institutionalizing their own learning within the healthcare system. So whatever new evidence is being generated by whatever you consider learning health system, how is it being made part and parcel of the continuous cycle moving forward? Whether it is through deliberative learning, which is more focused on advocacy and negotiated positions on how that data can inform decisions, which is difficult to envision in our space, given that there's very limited activity in that area, or it has not yet been exposed enough to know what actually happens. But lastly, within the institutionalizing of learning, it's the giving space for actual frontline healthcare providers and local facilities to actually conduct their own experiment ideas on how better they can improve, and then use that information that they're generating in terms of learning and to feed it back into the entire system. So this is actually, I find this to be a very easy way to kind of think through learning health systems and what they should do. So remembering the point I made around our the periodic surveys, which are not even that periodic, their focus has always been on monitoring and evaluation approaches that are very command and control structured, based on hard targets that are based on summary measures. And so the question there is always, has this hospital met the targets? Yes or no? We should do more to make sure that they meet the targets. But we're trying to move that conversation a bit further along and go like, let's pause a bit and ask, from the information that they're generating, given the realities that they're facing when they're providing that care, I mean, the resources that you might be assessing might not even be present at the time you're assessing them. How do they make meaning of that information that they are interacting with? How do they actually see their own learning taking place? How do they use that information to change the way they're practicing within their local setting? So it's kind of trying to think through the ways in which they're already using data that is not yet exposed. So you don't have to assume that there's no use of data. If we know their function, we want to know how and what informs that function. So that will have to be exposed in terms of experience maps, user journey maps, working through clinical scenarios and those activities. But secondly, what we'll also be keen to explore in terms of information use culture and value proposition is trying to think through the ways in which the healthcare providers and the facility managers interact with the clinical guidelines that are presently there, adjust their actions based on those guidelines, the ways in which they actually consider new ways of functioning just to keep up with the current guidelines, or the ways in which from their own learning, they actually seek ways to alter the current functioning of the processes within their own local health facilities to make sure that that learning actually leads to actual improvement of patient care. So that kind of creates a distinction between just adapting already existing guidelines to practice and measuring against the hard target to more thinking through, okay, if they were not able to actually adapt it, in what ways did they actually modify their actions in such a way that they are making care that is actually might be considered to be consistent with the guidelines, or in their thinking think it's better and why they think it's better, but also if they learned something from that process. And I'd be happy to give examples during the question and answer session. How do they actually reintroduce it back into their own setting in such a way that it's now part of the way they do things, so institutionalizing the learning. And we're going to focus on two particular clinical scenarios. The possible signs of bacterial infection, which is linked to neonatal sepsis, and the respiratory distress syndrome, primarily because they give us also good use cases to track things that are of importance to local health, such as antibiotic stewardship, antimicrobial resistance, how you're handling respiratory conditions, considering COVID-19, how do you prepare for the next pandemic? So they're kind of like exemplars that allow us to start thinking through like ways of doing things and functioning within the health facility that prepares us for the next pandemic, next emergent problem, but also allow us to do better clinical surveillance. As I mentioned, it's going to be a mixed methods type of research project. There's going to be a lot of work in terms of in-depth interviews with the nurses in the hospital wards, the medical officers, the neonatologists who are ward managers, but we're also going to do a lot of observations of the quality improvement meetings, do walkthroughs during ward round, attending health management team meetings. And the goal here is to kind of try to expose the ways in which people are interacting with information as they're making their decisions, with the goal of uncovering opportunities for strengthening that and improving that, to allow for better provision of care. But thirdly, one of the key areas to extend this work in terms of trying to build a more resilient learning health system is to think through the ways in which such information can be used for deliberative learning. I say deliberative learning, but that can also be interpreted as advocacy, a bit of advocacy work. So how do you start using that information to advocate for resources, improvement of practice or change of behaviors, not just with other clinical team members, but think about the politicians who are in charge of the resources, but don't care about, they don't care. They don't prioritize whatever you think is important. So trying to build a learning health system in a way that people can actually start using their own data that they're generating from their own practice to do a bit of advocacy work, and also trying to negotiate for more resources for specific conditions or instances, which is going to be like a consensus building Delphi type work approach with lots of team activity. But the second bit is going to now be more focused on the building the feedback loop from the once the consensus has been reached about the clinical cases, how you want to integrate them into the routine care. The next bit is co-designing what would be considered a nationwide, I hope so, a nationwide intervention to kind of try and track a specific clinical condition using the data that has been generated from these paper forms in a way that allows the people who are generating this data to, apart from learning from it, to start using it for things like the deliberative learning process. So the advocacy work, the bit of quality improvement programs that are more frequent than the periodic annual surveys. So this is recent work that has just started. I think like I'm in six months in so far, and I still have 3 more years. So we are at the stage where we just finalized the design of the machine readable forms. We are in the process of rolling out these forms for use. Thankfully, we are doing this in partnership with the Ministry of Health and Care. So we've allowed at least them. We've used a policy window in which they are trying to launch harmonized forms to to kind of latch on and try to think how these machine readable forms can be used in those particular hospitals that are being, the harmonized forms are being piloted in. And with that, we also developed the models that need to extract the information from those machine readable paper forms. I can confidently comment that the performance of those models is exciting to me, to the extent that I am worried that I might be overfitting. So, so we want to at least test this out with a bit more hospitals. So we are hoping to get to a target of like 20,000 patient admissions. So to 50 variables for 20,000 patient admissions over a period of 1 year. So different people documenting the paper records with different handwritings, with different institutional practices, and try to see how well we perform when we try to start the data compared to when somebody does it manually. And then so with a lot of those forms, we also started the qualitative bit of work. So doing a bit more interviews with the hospital workers, the managers, the doctors, the nurses, and doing a bit more observations. We just started out in one hospital where we are planning to start attending the quality improvement meetings, so that we start trying to build those links between the existence of those forms, their use in the wards, and the information is being undertaken, and how those two are linked, and try to kind of paint a picture of that. And that's about it. Thank you very much.
Thanks very much, Tuti, and quite impressive, I must say, especially given the fact, and I don't think everyone's aware of that you've been traveling for the last 30 hours and had time to sleep for about 2 hours. So yeah, pretty tough, but great talk. So we've got time for questions. For people online, if you could put your question in the chat, I will read them out. But let's start with taking questions here in the room. Anyone who wants to go? James.
Thank you so much for the talk. It was fascinating. A question I have is relating to the records. What do you find doctors prefer? Do they prefer the in-paper records, or do they prefer a digital system when they're collecting patient data?
There's some previous work that we have done doing like surveys on how the digital health records are being used in public facilities in Kenya. What tends to happen is that most of them are used in the outpatient part of the hospital, and they're primarily being used for billing. And the high volume processes that generate money for the local facility, like X-rays and lab facilities. And so there's very limited work going into linking digital health records with actual needs and flows of the way clinicians actually do work in the hospital. Now, the paper records, thank you for bringing this up, because I had forgotten to mention this. The way those paper records have been designed, they reflect clinical guidelines, such as the WHO guidelines for providing care, and they actually linked to the way care is provided. So all the fields in those forms actually link to something about care and the way it should be provided or is being provided in the local setting. So they reflect better the clinical processes than any digital health record you've seen so far in the setting. And I think that is true from a systematic review in sub-Saharan Africa in general. It's paper records are outpacing digital health records simply because digital health records are not designed to actually improve care.
Thank you.
Other questions, Matt?
Hi, thank you. That was a really good talk. I've been looking at how hospitals use forecasts, and a big issue is around the degree of trust people have in A, the source data, and B, the methods for producing the forecast. So with your study, will you be looking at any kind of measures of data quality and thinking about how you might go and communicate that to the end users of the data?
Yes. So within the arm of audit and feedback intervention, one of the things we'll be exploring is how to better design the feedback about the quality of the data that they're generating in such a way that allows them to build trust in that data. I think this is a good point to just point to a previous study that I've just finished doing, but it looks at audit and feedback in improving gentamicin prescribing errors in neonatal care. And one of the things we found was that people initially want to challenge the quality of the data, but once you start providing the feedback in a way that they can actually interrogate the data, go to the actual records department, look at that form, and once it starts like ringing true that actually whatever the reports are showing is actually what happens in the hospital, the convention now shifts to now making use of those forecasts, those types of what would you like to see kind of questions and how you want to improve. So I think in clinical information network, we've been doing this for a while. For this particular project, we need to start thinking about where hospitals have never had interaction with their own data and how to build trust in that data. So that is going to be an output of this project, but it's going to be more of a proposition for a research project that can be done at scale outside the clinical information network. Is my short answer. But I have more comments which I'm happy to about that issue.
Yeah, it can be a really thorny issue. I've seen it as well. I think especially, if there are systems or information resources in place which no one trusts, and those exist also here in the NHS. So once you start using those, everyone would just say, "Oh, that's just completely rubbish." No one looks at that. It's just completely unreliable. So I think, the challenge is to stay away from those kind of things.
And maybe to be upfront about the degree of uncertainty. So if you can say, 5% of these records are reliable, then people can use that when they come to their decision.
Yeah. So I think one of the things that we're going to do, at least in the consensus approach stage of validating this, is not only validating trying to think about that deliberative learning bit, trying to avoid the bits about data information and model fitting and how that features into this project. But what we're going to also test is how much uncertainty is acceptable to the people receiving this information, so as to allow them to make that any information is using it. So if you get data on 100,000 admissions, but it shows that the models tend to have 90% accuracy, compared to getting 5,000 records and you're being told the models have 92% accuracy. Is that difference of 2% so significant that you cannot use the previous 100,000 with a lower? So those type of questions and thinking through how that can be packaged in a way that it's known to those who are consuming it, to build their trust in also the models themselves, is going to be part of this.
There's been a question online from Anitha. I hope I pronounced that correctly. Actually, well, let me go to Anitha's question first, and then I see there's a couple more questions actually from Chris, which is great. I'll start with Anitha's question. So, and I think this is really interesting. It's a good question, because I think that, a lot of the challenges that you describe, we basically have everywhere. We definitely have them also in the UK, but for slightly different reasons. So for instance, here, I think we have relatively few paper-based resources nowadays. So most of the things are digital, electronic, but we're quite concerned about privacy for very good reasons. But that makes the kind of thing you're trying to build up extremely hard, because you have to go through so many hoops in order to, bring different information resources, for instance, together. So question from Alta is this a concern in Kenya? Would you expect, are you coming across similar hurdles in Kenya?
That's a difficult question to answer because everything is so new. So we just recently have a new Office for Data Protection, which kind of outlines how, even in research, which data points we could or could not use, and because of questions around privacy. Secondly, because most of the research that is being conducted in our setting is retrospective, so when the patient has already been discharged, it's quite hard to go back to those patients and try to seek permission, because also information around where they live, contacts, there's very poor linkage. So the way we are thinking through this is, number one, whether there's opportunity to actually decide what is allowable in terms of privacy, not privacy, but this is going to take a top-down approach. So what is allowable for the policy makers and the people who are initially these offices, and then work downwards. I hope as this research progresses, we can flip that and start using things like citizen juries, which I thought was a brilliant idea from Manchester. So trying to engage the actual patients with the users of data and try to see what they think about that and how that can be used to frame the question of privacy and data use in our setting. Yeah.
But yeah, sorry, it might also be worth just flagging up though that you're not collecting personal identified, more formal personal identifiers. And in places like Kenya, there is no such thing as an address, for example. So in fact, I mean, it clearly is still a privacy risk, but the risks are lower because it would be much harder to identify an individual.
Yeah. I like this as jury's approach, obviously, so I'd be very happy to help with that. Then there's a question from Chris. Hi, Chris. And what time is it over there, by the way? New Zealand. So Chris asking, are there examples of other places or countries, that have used these machine-readable forms for medical records? Is there any experience, any evidence on that? Does it work?
Yes, so there's some experience. And countries like Ivory Coast, Senegal, I think Tanzania in some specific programmatic work have used this hybrid paper to digital mechanism. I want to give them benefit of assume it works, because most of the reporting, the problem with the data warehousing tool that we use, which is the DHIS, that is used in most African countries, but most reports about the DHIS usage come from the DHIS. So it's like, okay, maybe you're trying to prop up your technology. So, but from the examples I have seen, it seems to work quite well. And there's even examples of where they used it, like, for example, data advocacy bit to kind of campaign for resources, for interventions, and this was in the Ivory Coast, I think, but and it's in the West African country. So we have some degree of confidence that this approach can actually work.
Yeah. Some degree. Well, Chris is saying it's very late there. So, right, I had a question myself as well, actually, and you alluded to this in your talk already. So my experience with audit and feedback interventions is that very often, if it does work well, then local teams, the feedback that they get helps them to identify the problem and then come up with a solution. And very often that solution is, well, we actually need a little bit more resource. We need a new device, a scanner, for instance, or something else that we haven't got at the moment. Or we need, a person, half a person added to the team who could do something. And that's really, what the bottleneck is. And then they have to go to the people who control resources. And, well, they wouldn't always say no, but then it becomes a very lengthy process. And sometimes it just doesn't happen. or the actual results only happens after your study is finished. So yeah, I think you've thought about this already. So what do you think? What's the best way to deal with that problem?
Well, that's difficult because on the issue around like advocating for more resources and whether that can actually driven educations in our settings, I think we can speak about it because there's a certain project that is ongoing with the Clinical Information Network that has done such interventions. I don't know how well they worked out, but so the question around the audit and so that using that feedback to go do a bit of advocacy for resources to improve the actual health system, I think I'm hopeful that the space we are in as a country politically will also prove as a window in which we can start introducing these ideas, which is not to plug politics in Kenya, but the last 3 weeks have been very interesting for the Republic of Kenya. For anyone who has been tracking the politics, I think the political system has been turned upside down, where there's more push for things being driven from the bottom. So the people who act with the actual systems and whatever, having a bigger say on how things are being done. And so right now, everyone from the head of state to is kind of thinking through how this, what does this mean? And I think it's a wonderful time to do this piece of work because I can also introduce ideas, especially with the Ministry of Health, with the Pediatric Association, on how we can institutionalize that process of this is a sites are generating, this is the decision-making platforms. We need a more clear link and more quick responses to such some of the things that we're raising. So it's a good time to start that conversation. Yeah. I'm not ambitious in the, I'm not ambitious. I'm not idealist in terms of thinking that at the end of this research project, we'll be able to do that. I think for this particular project, if we're able to move that conversation and start thinking about tools, processes, frameworks we can use going forward, that would be a win for me. Yeah. Because the issue about feedback, it's I have more comments. I think I can wax lyrical at this point, but let me pause it for now. No more questions.
Right, Mike.
Well, I wanted to ask, you've just touched on it now, and I thought it might be interesting for people in the room. I mean, you started life as a computer scientist, you trained in social statistics with Niels and others, and you've carried, but what I'd like you to talk a little bit about what it means to do engagement and policy engagement, which is not something you ever thought you'd have to worry about in one sense, because some of you will end up on funding panels at some point in your life, and nobody knows how much time it takes. I'll just give you a little reflections on that part.
So I kind of give an overview. We work to the ministry. Sorry. I'm hoping to join the meeting. I've been working with the Ministry of Health to kind of launch the machine readable forms. For the last 6 months, that has become quite, I mean, that takes up like 60% of my time. And that is because you're required to attend meetings in which you're being given space to advocate for what you're doing. But for the most part of the meeting, it doesn't necessarily involve the work you're doing. So, but it's where the decisions that are being taken will affect the health system. So you need to be in that space. So that bit of just time through stakeholder engagement is quite, people don't pay much attention to how much effort it requires and how much time it takes. But secondly, so the idea that, so for example, you're testing new interventions, new ones in the officials. When you're dealing with stakeholders, especially at the governance level, you are tied to the policy cycle. So the elections, the change of direction. So you're working in a 3-year project. But halfway through, there was an election. Someone came who's a new minister who decided we don't like this anymore. We're shifting to a different direction. A good example will be when the new government came in, they said we're going to launch an electronic health record system for the entire country. Again, remember the debt distress and the amount of money it would require. But secondly, there's no one at the ministry who has an idea. There are very few people at the ministry who have an idea of what that looks like. And then the programmatic work like child health and how that affects that is quite unknown. So you're stuck in this gray area and you're dealing with stakeholders who can't give you a clear definitive answer of how to proceed. So you kind of have to wait around in the darkness for a while. And I think that's, I don't know how to, yes, I'm a computer scientist, but I'm finding myself doing a lot of politics. That's what I'm looking at.
Yeah. Right. Final question.
Hi, thanks, Tuti. Fantastic talk. I was wondering about the data capture. Is it possible? I mean, what's the role of smartphones in terms of immediate data capture and recall into like Google Translate, for example, and those kind of technologies? Would that work?
That is one of the. Remember, I started out saying that when I showed the analytics structure that we are starting out with, which is scanning the paper record and converting it to, applying the models to extracting the data. That is another modality we have thought about, which would give you near real-time data. And one good use case, which I hope to test out, not in this fellowship, but maybe in another one, is running a clinical prediction models on those particular image using object detection models, so that you are at the time of admission, as the patient is being plugged, all you need is check out your tablet, take the photo, and get the score from the variables immediately, as a way of trying to kind of build a decision support system that is kind of hybrid paper-based. That will take a bit of doing. And secondly, the privacy issues rear their head. Whose tablet are you using? Is that information being stored in that device? How do you, is it like how the resources required in terms of tablets, phones, who's going to kind of incur that cost? And they're going to be managed within our setting. There's all those questions about technical feasibility of doing that in terms of actual implementation, but the models on the paper, it's we've tested it. It does reasonably well at the moment, but we need more data.
Right. Sorry, I'm going to. So before I do that, I'd just like to thank our conference engagement team, who's done a fantastic job in organising this seminar and the lunch that is to follow. So thanks, Suzanne, Yoon, and Faye. And thanks, Tuti, again, for a fantastic seminar.